Okay. Okay, I will tell. Vipul, some are wanting to join and they are not able to join. The host is not letting in.
So they are now all added.
Okay, Dr. Shaila has also joined. So then let's start now. It's 7, and I welcome everyone to the second part of our transplant update. And today we have Dr. Vikas Dharnidarka, who is going to talk to us about choosing immunosuppression in renal transplant by efficacy and morbidity. So Vikas, I think you had done this once when you visited Global Hospital also, and we look forward to your presentation on how you choose immunosuppression in your clinical practice. So over to you, Vikas.
Thank you, Dr. Shah. I'll just, if somebody can give me the share screen privileges again, I will pull up my slides.
Vipul, please allow him to share.
Yes, sir.
And can all of you see my main screen now?
Yes.
Thank you, Dr. Shah, and to the Narmada Kidney Foundation. I remember coming to Global several years ago and presenting the work that we were still doing then. What I'm going to present to you today is actually the completion of some of the work that we have done, and then the web calculator tool that we have developed for everybody's use from this work. So we took this title, Choosing and Personalizing Immunosuppression Regimen, because we wanted to look at a global perspective on what kidney transplant recipients might look at for outcomes and what would be important to them and to the transplant professional. So my disclosures, I am a consultant to Atara and another company, Medincell. This work that I'll present to you was funded by the NIDDK, the National Institute of Diabetes, Digestive and Kidney Diseases branch of the NIH. That is this one that I'm circling here. And I also get some support from a company called CareDx, which does cell-free DNA work. So in transplant immunosuppression, we have so many choices, starting with our induction antibodies, which can be either polyclonal, such as the anti-thymocyte globulins shown over here, or the monoclonals, such as basiliximab or alemtuzumab. And then on top of that, we can add oral maintenance immunosuppression, such as tacrolimus or cyclosporin among the calcineurin inhibitors, and then the DNA synthesis inhibitors, which could be any of the mycophenolates or azathioprine. We can also choose to give them low-dose steroids, and some patients may be on mTOR inhibitors such as sirolimus or everolimus. And then some patients may actually be maintained on a monthly injectable immunosuppression maintenance agent, such as belatacept for co-stimulation blockade. So just so many different choices of medicines, the combinations that you could use exceed 150. And how does one choose for a patient? Most of us in our centers will have specific protocols that we use. We may selectively try to create 2 or 3 regimens based on what we deem as high risk, moderate risk, or standard risk. And then we will try to stay within those combinations because we are comfortable with those drugs. We understand their side effects and how to adjust their dosing. But are they optimal for each given patient? We assume that the patients can be lumped into these categories. So the way to choose drugs has really come from as many trials as we could do. And randomized controlled trials have long been considered the gold standard. The reason being that there are many confounders to the outcome. And when you randomize a subject, you break the confounding for whatever is the primary outcome that you've chosen. And I've specifically underlined the word primary. This is considered the highest quality of evidence, but trials will also have a variety of secondary outcomes. And for this, there is no break in the confounding. The trials are typically not powered to look at the secondary outcomes, even if they were specified in advance of the trial or pre-hoc. So the limitations of randomized controlled trials are actually quite a few. they are very, very expensive to run, particularly in countries like the United States, and they are quite time consuming. They may take up to 5 years, 6 years for the trial to get done. Sometimes the question that was initially designed can become out of date. And then ethical approvals across institutions can be challenging, especially in our country. Each ethical board tends to have a different view of a trial. And informed consent is needed from subjects. Not all subjects will agree. And then sample sizes, though they can get into the few hundreds, that's still a relatively limited sample size in context of the total population that we treat. And then follow-up for these trials, because of the expense, tends to be short, 1 to 3 years, whereas most of us maintain a long 10 to 15-year view in terms of how long we want the patient and the allograft to survive. Finally, we may all choose for these trials the best patients in our practice, and those are the ones we enroll. That introduces selection bias. We miss the real-world experience of the less than optimal subjects. All of these make these trials less generalizable. So one of the ways to get around this is to take advantage of existing sources of big national level data. And in the United States, we are fortunate to have several such sources. The first is the Organ Procuring and Transplant Network, or OPTN. This is a mandatory registry for all solid organ transplant recipients in the United States. And so every center has to enter data in here. And this was awarded through a federal law and a federal contract back in 1988 to the United Network for Organ Sharing, a private agency. So they run the OPTN. And a related database called Scientific Registry of Transplant Recipients, which is run through Minnesota. They have a separate federal contract to perform research on the data that is accumulated through OPTN. And so this has been in existence now for more than 30 years. In addition to this, we also have access to something called the United States Renal Data System, which was set up approximately the same time in the late 1980s. And this is a kidney failure database collecting data on adult patients and children also who have kidney failure, primarily dialysis, but also kidney transplant. And this is primarily for the patients who have what is called the Medicare insurance. It is a type of governmental insurance for the patients. And for them who that is the first or primary type of insurance, their data gets collected into this system. Now what we can do, this is the equivalent of this system would be the Australia, New Zealand ANS database. So in the USRDS, they actually have available what are called Medicare claims. So when we submit any data to an insurer, we have to submit a formal claim to get payment, and we have to associate diagnostic codes for that. In the time that we did the study, the United States were using what were called ICD-9 codes. Now we have shifted to ICD-10. And this means that though it is a voluntary system of reporting, it's incentivized, because if we do not submit a claim, we do not get any payment. So these Medicare claims are available through the USRDS. The USRDS has outcomes data for up to 3 years, because in the United States, the kidney transplants are covered for the first 36 months through Medicare insurance, primarily for the most part. And so we can judge from the ICD-9 claims what are the outcomes. We can judge from the linkage to the OPTN or the USRDS base data as to what's the primary disease and what were the peri-transplant outcomes. And these kind of big data have been used by many groups, including ours. And Dori Segev and Alan Massey published this review article a few years ago, showing the different types of data available. I mentioned to you the first 3 here. I will not talk today much about the inpatient data sets that are available also. So our medications come with multiple adverse effects. Each of them suppress the immune system. You get urinary tract infections, sepsis, pneumonia, and I'll explain why I chose these 3 to highlight on an upcoming slide. We also see malignancies, because immune surveillance is an important component of cancer surveillance. So there can be viral driven and non-viral driven malignancies. And then new onset diabetes after transplantation is a complication we see a lot. And then there are the cardiovascular complications, dyslipidemias and hypertension. Now the medications that we started using And if you go back all the way to the original medications used in the 1960s onwards, that's shown in the x-axis over here on the graph. Initially, the drugs used were prednisone, 6-mercaptopurine, which is a precursor for azathioprine, and then body irradiation. And at that time, the acute rejection rates shown in the red line were very high. The first year acute rejection rates were 80%. Most patients were told to expect at least one episode. And allograft survival in the first year shown in the green line was very low at only 40%. So we got better and better, we being our peers and predecessors, in trying to make improvements on this, got to a point where we could make the lines cross and graft survival got up to about 65, acute rejection dropped to 60. And then cyclosporin was introduced, and that helped make a big jump by about 25, 30 points, got the graft survival up to the 90% range, and first year acute rejection rate down to 45. Other drugs, the monoclonal antibodies, OKT3, tacrolimus, mycophenolate, the various other antibodies, all of these were introduced and then took the first year allograft survival up to 98%. Acute rejection rates have dropped now to about 10 to 15% in the first year. Simultaneously, though, what we started seeing from the mid-80s onwards was a proliferation of cases for CMV, and then in the late 80s, 90s onwards, EBV-driven PTLD. And then in the late 90s onwards, we in the kidney transplant field started seeing a proliferation of cases of BK virus allograft nephropathy. The height of each of these bars is meant to represent the rough incidence of those complications as they became prominent with more increased immunosuppression. So you can see that even with some overlap between the three, the cumulative instance of those three probably exceeds the incidence of acute rejection in many programs, depending on how potent your immunosuppression is. So how do we then judge what complications are acceptable versus what efficacy we desire? And why not use prospective trials more for that? As I've already mentioned to you, these are expensive, short-term, and in my estimate, they only answer 1 out of maybe 100 questions we might have. So this table from the grant application we had used to fund our initial study shows you that looking at the annual report of the US RDS at that time, these complications of sepsis, pneumonia, and pyelonephritis or urinary tract infection were very common in the first 3 years after kidney transplant. These are all mostly adult data, so 30, 25, 33% here. But then if you look down the rows here, all of these other names that I mentioned are different prospective randomized trials that were conducted in the transplant field. The word NR shows up the most. That means not reported. That means all these trials did not even have a data element to look for whether these complications were occurring, even though we already knew from the USRDS report that they were quite common. Only 1 trial reported for sepsis, 3 for pneumonia, and a fair number for pyelonephritis. So this is the challenge, that we have focused a lot on acute rejection and allograft survival, patient death, but there are so many other complications that are important to the patient that we have to be cognizant of. And here's an example of one of those database integrations that we did. This is work I did with a collaborator, Kevin Abbott. We were merging the USRDS data with the OPTN data at the time and looking in adult populations for what were the factors, risk factors associated with specifically with major viral infections. And you can see the adjusted hazard ratios for a variety of different factors, some of which are controllable, some of which are not controllable. The challenge with this kind of research at the time we were doing it is that we only had the ability to assess complications at any time points with the initial immunosuppression that happened at the time of the first discharge from the hospital after the transplant. And those were data that the OPTN could capture well, but then there was very poor capture of the subsequent immunosuppression changes that happened through the first year. And we all make multiple medication and dose changes during that point. So even the initial choices of medications are predicated on some initial risk factors that we utilize subconsciously. So how do you adjust for that? Luckily, at that time, this was back in 2012, 2013, we also obtained access to a national level pharmaceutical claims database, which had patient level prescription claim records from multiple sources, not only from the data clearinghouses, from retail pharmacies and what are called prescription drug managers that do mail order prescriptions in the United States. And these covered a large population of the US prescriptions, 60 to 85%. Through this, we obtained records of the medication fills that were insured and even self-pay. We also were able to get the specific identifying agent through the National Drug Code, the date of the pharmacy fill, the quantity dispensed, and the cost. And this applied to the transplant immunosuppression medications, as well as other medications, anti-infective, hypertension, and other chronic kidney disease medications. Now we had the ability to be able to look at what was happening through the first year. What we did with the approval of our institutional review boards, we successfully linked direct patient level identifiers. So we knew the unique anonymous OPTN identifiers for the transplant patients. And we actually utilized a strategy where we sent the data, or we had the agency send the data to a third party under contract. A third party then used encryption technology to de-identify the identifiers and then link them together using different multiple algorithms.
Recording in progress.
So that we would be able to do whatever research we wanted to do, but we could not decrypt the data. And the algorithm would yield the same results over the totality of the population. So this was the study called Choosing Immunosuppression in Renal Transplant by Efficacy and Morbidity, system study. And we had this grant through the NIH for a purpose. And we can see the linkages we did here, the OPTN to the PCD, and then down here, OPTN to the Medicare claims. And then finally, the anonymous linkage directly to get a three-way linkage. First time that, to our knowledge, anybody had done this kind of three-way linkage. And here shown in this graph is the paper that we published in 2016, where we actually looked at all of our data and combined the results. And I want to acknowledge here my collaborators. Mark Schnitzler is an economist who has worked in the transplant field. Krista Lentine and Daniel Brennan are transplant nephrologists. And then David Axelrod, Dory Seger are transplant surgeons. And Ken Sheckman, Ji Zheng were data analysts and biostatisticians. So a multidisciplinary team. And what we had here was a population of Medicare insured kidney transplants that we looked at from 2000 to 2011. Starting population was about 71,000, so very large size. And then the ones that we had Medicare reimbursed pharmacy claims were about 47,000. And we got to a point of trying to determine what were the different immunosuppression regimens. There were so many possibilities, we had to lump them together. Took us about a year and a half to finally come up with 7 regimens that we felt comfortably represented most of the population, minus a very small group of other. And hierarchically, if anybody was on cyclosporin-based immunosuppression during that time, then they were lumped into that group. If they were on sirolimus-based immunosuppression at that time, they were lumped into another group. Everolimus was hardly used during that time period. And then sequentially going upwards, we had these other regimens of tacrolimus, mycophenolate, prednisone, induction types or no induction. And we utilized a tacrolimus and any mycophenolate azathioprine plus prednisone plus thymoglobulin as our reference regimen, which as you can see was the most common use in our country at the time. These were the different ICD codes we used for new onset diabetes after transplant, pneumonia, sepsis, pyelonephritis, UTI, different types of cancers, which we lumped into non-melanoma skin cancer, viral driven, or other cancers. And here what you can see were the 3-year predicted outcomes of incidence of these different complications. Looking at the different regimens, each are represented in a different color as shown in the bottom. And then each of the different outcomes are shown over here. These horizontal bars represent the incidence at 3 years, which you can see the most common was pyelonephritis and UTI was seen in almost 50%. And then viral linked cancers was seen in a much smaller percent, as you would expect. Patient death rates, death censored graft failure, you'll notice immediately that the green horizontal bar has a much higher number than the others. And this was statistically significant by the symbols represented here. And that was off the sirolimus-based regimen. Now, interestingly, what you'll see is if you go to the top of this graph, you'll see that that same group, which you might think was under immunosuppressed, also had a higher instance of pneumonia and sepsis, which would represent potentially over immunosuppression complications. So these are not linear things that immunosuppression goes on one end to the other end of the spectrum. And we believe these data are consistent because we saw some other things that we adjusted for covariates. Here, these are not adjusted in this particular slide, but then we did that in the slide I show you over here. So now we took the thymoglobulin plus prednisone plus tacrolimus and the mycophenolates as our reference regimen. That is represented by the horizontal dashed line on both graphs. And the other 6 regimens are represented in these different symbols over here for the different 10 outcomes, the 5 shown here on top and the 5 shown here below. And adjusting was done in 2 ways. One was a propensity matching to try to adjust for choices that you might have made right in the beginning, and then a subsequent Cox regression adjustment to adjust for confounders beyond. So still, you can see the data show the same trends. The sirolimus-based regimens had a higher adjusted hazard ratio for patient death or death-censored graft failure, and also for pneumonia and sepsis. Now, these data, I think, are consistent with other literature because the sirolimus-based regimens did show a statistically significantly lower risk for non-melanoma skin cancer, that's shown over here. And then new onset diabetes after transplant was significantly lower if you used a prednisone-free regimen or if you used a cyclosporin versus a tacrolimus-based regimen. So based on these data, and we did this in unbiased fashion, we did not come into this expecting to find any specific regimen would be worse or better. And in fact, if I go back one slide, what you see is that many of the other regimens, such as the IL-2 based regimen, they performed equivalent to the thymoglobulin regimen even after these adjustments. There were no significant differences in those. So the final part, which I had not presented when I came to Bombay last time and presented to Dr. Shah's group at Global, was the creation of this web-based tool. We did not want to just show you what data we had. We wanted to give you an opportunity at the time of transplant, with the data available to you then, to be able to see what kind of personalized immunosuppression choice might be appropriate for your patient. So this took another few years to finally do. We had to create a new set of JavaScript language based on the data we had available at the time of transplant, eliminating everything else. And these are the 2 URLs you can see for it. Because our study was named System, one URL says CISTM, but another one, immunosuppressioncomplications.woostel.edu, might be easier to remember. Woostel stands for my university, Washington University in St. Louis. And so that is the web host for these programs. And these are sites that you have to put the HTTPS. Without the S, it doesn't actually come up. But if you do put that in, then you will see a web page that looks like this with this title. It is hosted through my pediatrics department, but all the data that I've shown you was derived entirely from adults. All the work was entirely adult kidney transplant based. And so then what you will get in that, I'll show you in a second, a few disclaimers for it. This is guidance. It's meant for kidney transplant professionals to help with their patients, and you will get benefits and risks of different medication regimens. And it is not meant for use by patients who receive a multi-organ transplant like kidney, pancreas, not meant for under 18. We've derived it entirely from US-based data. Not sure what might be the applicability to other parts of the world. But the page does work on multiple different types of browsers, and it also works on multiple mobile devices. And what I did over here in this particular page on the slide is I went to the data link, which is on the top of that page, and then I've inputted a variety of variables for you in advance. So for instance, this recipient is age 50, male, black race, 5 foot 10 inches, 170 pounds. And he already has diabetes as his cause for end-stage kidney disease, has been on dialysis for 36 months, had a transplant, and therefore has a high panel reactive antibody of 88%. And HLA matches, he's not a low mismatch or 0 ER or AB, so he's on the upper end of that, and has delayed graft function. So all of these put this patient at high risk. And then there are a few donor criteria that you see there. At the time we performed these analysis in the US, we were still using what were called standard and extended criteria donors, which has now since changed. But that's why we had to stay with that on this tool. And then once you input those and submit, what you get are graphs that look like this. There are several graphs. This is the first of them. And you can actually export this to a PDF through this button and print these out for the patient. So the different regimens, the same 7 regimens that I showed you earlier are shown in the legend here, and they're represented by regimens 1 through 7. And then the same outcomes that I showed you earlier are represented in the different colors. And what you can see is with each regimen, you get a sense of what will be happening to a particular outcome. So if you're interested in patient death, for instance, that is the red bar or the orange bar, you can see across the different regimens which might be important for this specific patient that we did. And then going forward, you can also see for each of the different outcomes separately for the skin cancers, viral linked, other cancers, sepsis, pneumonia, urinary tract infections. This patient already had diabetes pre-transplant, so the numbers are deliberately going to be 0 in this, and that is what you see on the legend. So this way, the transplant professional and the patient can actually see what outcomes might be important to them. A patient might be particularly worried about diabetes risk, or might be particularly if they have a history of cancer before. For them, cancer risk might be more important. They might be willing to accept a little bit more risk on the other outcomes if they can reduce these. And that's the point of this personalization. So to summarize, these kind of big data research with triple linkage has allowed us for analyses of the regimens that you get through the entirety of your first year, 2-3 year outcomes. And then through this tool that we've developed, which right now is available to everyone, we set it up live in July. You can look for guidance to get some kind of personalization. And we hope that these kind of big data will allow for more of that in the future. Thank you for your attention. I will stop over there. Here are my contact information, our email, my website, and then my Twitter account. I'm happy to take any questions.
So thank you, Vikas. That was an excellent talk on selection of immunosuppression based on efficacy and morbidity. And you have done some wonderful work in collecting the data. I'm sorry, in my effort to start the program on time, I missed out introducing Dr. Vikas. Dr. Vikas is Director of the Division of Pediatric Nephrology and Hypertension at Washington University School of Medicine at St. Louis. And as you can see, he has done a lot of work in compiling data on the efficacy of various immunosuppressive regimes. My question for you, Vikas, is that do you use your score while choosing immunosuppressive regime for all your patients going for transplant, or you decide it based on the morbidity and various factors based on your experience?
My clinical training is in pediatric nephrology, and therefore I take care of children. My research takes me in dimensions outside of my clinical training. So I work in adult kidney transplant, or I work in PTLD areas, which take me outside of the kidney world also into other organ transplants. So I cannot use this tool for my own patients because we deliberately stayed away from children for it. But my colleagues who are transplant nephrologists, transplant surgeons are currently using this tool.
Okay, so it's a standard thing to use the score in deciding the maintenance immunosuppressive regime.
There's not a score here, and that was something we deliberately decided in advance, that we would not create a score. We did not feel that we could weight the different outcomes for a patient. Each patient, right, each professional, may how you want to weight it. So we are giving you the different percentages of the incidence and the risk, and then you get to choose what you think might be more important. For a given patient, the diabetes or cancer risks may be more important, but others may say, no, we want the allograft to survive, or we want our life to be extended. And then you get to choose what you want. So there deliberately is not a score.
Super, super. Vikas, I would like to ask you about one case that I had recently. This was a man who is about 40 years old, who had a HLA matched sibling donor. And being a full match, we decided not to use induction and not to use steroid for him, so that he was only on tacrolimus and mycophenolate. And he did very well for 2.5 years. And to our surprise, he presented after 2.5 years with swelling of the neck, which on biopsy turned out to be diffuse B-cell lymphoma. So what surprised me was that despite so low immunosuppression, he presented with a post-transplant lymphoproliferative disorder. Any comment on that case?
Yeah, it sounds unusual. Generally, the higher the potency of immunosuppression, the higher the risk for PTLD, but that does not eliminate the risk to use just 2 drugs, and 2 drugs is still immunosuppressive. Was this PTLD EBV positive?
No, it was EBV negative.
Yeah, so EBV negative PTLDs have a steady incidence that keeps cumulatively increasing over time. EBV positives have that big early bump. Your patient was 2.5 years out for there. And did this patient have any other malignancy history or underlying cancer risk?
No, no other risk. He was otherwise uneventful. He was actually a preemptive transplant. So absolutely clean history, and we were very surprised. In fact, when he presented with lymph nodes, we thought it will turn out to be TB in India, and to our surprise, it turned out to be diffuse B-cell lymphoma, which again was EBV negative. And then I thought by reduction of immunosuppression, he might improve. So what I did was I discontinued his tacrolimus and mycophenolate and put him on everolimus. And then I observed him. But actually that lesion increased in size, and eventually we had to treat him with rituximab.
Nowadays, rituximab is becoming first-line therapy based on the European trial, with the immunosuppression reduction being for a very short initial period. And if you can get a good response with rituximab, that may avoid chemotherapy in some patients. There is a baseline risk with any immunosuppression. The early PTLD cases came when cyclosporin and azathioprine were being used. So 2-drug immunosuppression can create PTLD risk, and tacrolimus is more potent than cyclosporin. I do see one question in the chat box about whether PTLD risks have increased in the COVID-19 infection rate. I'm not aware of any data about that. I haven't seen anything. I don't know if the person asking the question, Dr. Rajput, have you heard or seen anything about that caused that question?
Prashant, you'll have to unmute yourself. Prashant, you will have to unmute.
So, yeah, good evening, sir. So this was our observation, what we saw during this COVID era, where for a big chunk of time we didn't have any PTLD case, and suddenly we saw 6 back-to-back PTLD. All were patients who were diffuse large B-cell lymphoma, and they had COVID or had COVID antibodies at least, and most of them did very well and were treated with reduction of immunosuppression and RCHOP. So this was just an observation, and we don't know whether this is reported elsewhere or not, but definitely this was our observation that most of these patients had COVID or had been exposed to COVID previously.
I have not heard of anything like that. So if you have seen that, I think you should report it. I'm not sure what the mechanism might be there, because if the patients developed COVID, I don't know if their immunosuppression was reduced at that time or not. That would actually help you think in terms of preventing PTLD. So could this virus lead to something else that allows EBV to replicate as an indirect mechanism? Would be interesting to look at.
Any more questions? Shruti, any question?
I think it was a great presentation, and the tool is really great. We can try using it for a few patients. We do use immune stratification for our patients in our team when we transplant patients. Like we do a detailed analysis for immunology. We do a detailed analysis for their morbidity factors as to their risk of infections, and then we decide their low risk for immunosuppression or high risk for immunosuppression, low risk for rejection, high risk for rejection. But a tool, I think, does help, and I think it is a great tool which you have.
I may have missed out. Does that tool take into consideration the immunologic evaluation before transplant, like
Yes, there was PRA.
PRA positivity and all?
PRA and also the HLA mismatching are.
That was there in it. I saw that.
Okay.
So that's a good thing. And I think it can be still refined with the present situations. And like Dr. Vikas said that, it is applicable in the American population. We have to try and see how applicable it is in our Asian population.
And also the tool does need periodic updating, which we will
Yes.
try. The issue, we were using standard and extended criteria terminology back then. And obviously those are not used now. So we would have to shift to the KDPI scores. Those limitations exist because it takes time to develop these things, but they also do require, like any other software program, updates as things change.
So one more question before we go on to the next presentation, because as a pediatric nephrologist, what would be your preference for maintenance immunosuppression? How often do you use proliferation signal inhibitors as a part of maintenance immunosuppression?
Our standard right now is a thymoglobulin 3-dose induction. So we cut down the number of doses that we used, and then tacrolimus and mycophenolate. And in most patients, we go for a rapid steroid taper in the first week. So just only first 4 or 5 days of steroids and then off. And that's because we want our children to be able to grow normally. And so this is our preference. There are exceptions, patients with a glomerular disease where there's a chance of recurrence, or those that are retransplants or high PRA. Those patients would be on a maintenance steroid regimen where we keep them on it, but try to get to a very low dose of 5 milligrams a day as quickly as we can, and then just stay with that.
So your use of mTOR inhibitors may not be much.
We actually have been disappointed in our mTOR inhibitors. The rates of aphthous stomatitis were very high in our children, and that meant that they could not swallow any of the other medications. So we didn't use them early on because of the wound healing, but even later, the issues of aphthous stomatitis were quite limiting for our patients. I would say 25 to 50% of them had to discontinue the drug. And what we have done, therefore, is just use low-dose tacrolimus. Now, in your particular patient, the PTLD patient you described, what you did was 2 changes. You took out 2 drugs, tacrolimus and the synthesis inhibitor, and went to a single mTOR inhibitor, the everolimus. This strategy a lot of people do, and there is this conventional thinking that mTOR inhibitors are protective for PTLD, but the original data from Wyeth, when they did their studies and an outside group analyzed them, what was buried in that paper where they were looking at skin cancer, each time that the group got a higher dose of sirolimus or they got a higher overall immunosuppression in one study arm versus the other, PTLD rates went up. So sirolimus was not preventing PTLD, and a higher dose of sirolimus is associated with a higher dose of PTLD, higher rate of PTLD. So those are evidences I've used to show people that it may not be detrimental necessarily, but I don't think it is protective. It's really the overall potency of the immunosuppression we use. And in our children, there are patients who we still get BK virus nephropathy, not so much PTLD luckily, but a fair number of BK nephropathy, and we are aggressive in monitoring for EBV, CMV, and BK virus in our patients.
Well, thank you, Vikas, for that excellent presentation and the system that you have developed, and we look forward to using it in our routine practice. Once again, thank you, Vikas.
Thank you, Dr. Shah. Thank you, everyone.
We now have a presentation. As I said, our transplant update is essentially meant for enlightening us in our clinical practice and what we encounter. So for our next presentation, we have Dr. Shaila Kuchandani. Dr. Shaila is head of the Department of Pathology at Jeslock Hospital. She also is a visiting pathologist at Narayana Hospital, and she has her own laboratory. She is my colleague from medical school days, and for every problem that we may have, we resort to Shaila for guiding us for second opinion and in management of acute and chronic rejections. So over to you, Shaila.
Thank you so much, Bharat. So I'm going to start the presentation almost immediately. Basically, Dr. Bharat asked me to speak on just the pathology of rejection. And so I'm going to limit myself to that. I noticed Dr. Vikas did talk about some historical aspects, but I think the whole story started way back in 1902. It went on to a stage where, yes, the surgical part of it was improving, but till we got all our drugs in place, specifically cyclosporin, the program really didn't get on. What I am going to talk about is only the just the pure pathology and not go into any other details, so that I share as many images as I can with you. Now, as of now, we still have only the kidney biopsy available to us. Of course, we have our clinical features, but for separating out a lot of issues, we still do need to go into an invasive procedure like the like the kidney biopsy. And we know that it is still expensive in our country, but we do not have a choice in the situation of transplants. And in this case, the light microscopy is extremely essential, and we cannot do without it. In addition, the immunofluorescence is required depending, of course, on what our clinical features are, and that along with immunohistochemistry for the C4D levels to check out as to whether we have any features of an antibody-mediated rejection. Electron microscopy comes into play now and has been advocated that the tissue should be collected and kept for every biopsy, because other than if you're dealing with a situation which is immediate post-op, because chronic changes do set in the moment the kidney is placed into a new person. And to prevent any further damage going on, it is very essential, because the earliest findings are available only at the electron microscopy level. Now, most often when the clinician looks at the situation, he or she is going to look at it from the time angle, in that is the disease coming early or late, and sometimes they realize that both can happen pari passu. But when it comes to pathology, we are basically telling you the histology component and then trying to derive what is the reason why that has happened, and whether the lesion is still only purely in its active phase, or is it still going on into chronicity, but yet has some activity happening pari passu. Now, in this situation, it becomes very important to evaluate the donor factors, because there are sometimes some lesions happening far more often in some scenarios as opposed to a live donor, as opposed to a cadaveric transplant. Now, what is really required for us to almost reach a 99% of efficiency are two cores. But with one core, even 90% of the times you can give a very specific diagnosis. But what is definitely required, unlike in non-transplant biopsies, where sometimes we may get away with even one glomerulus because a large number of the lesions are diffuse, is that you must have 7 glomeruli and also you must have one vessel. In which case, if you do not have it, then your diagnosis always becomes tentative. Ideally, you should have 10 glomeruli and 2 vessels. And this is mainly for my junior colleagues, because if this data is not available, interpretation is virtually impossible. And I cannot emphasize that anymore. Today, I'm basically going to focus on just the allo responses of the rejection, which we now classify as occurring secondary to T-cell related T-cell mediated rejection and the antibody mediated rejection. So I'm going to get on with the pictures. And most often what happens is that these patients come within the first 6 months of their life of a transplant. And it's very rare that you have this kind of histology appearance occurring in patients who have come far later. And I think most people would recognize over here is that there is definite marked increase in the number of cells that you can see in the interstitium, wherein if you look at the cortex, when you take a biopsy, you should have no space between the tubules. But here you can see that the space has increased so much due to the large population of inflammatory cells, predominantly very small lymphocytes where the cytoplasm is barely visible. So this is the first situation that you have to see. The higher power view will just show you that you can see a tubule here, and the rest of the photograph, you can see that there are only small little cells, which are lymphocytes, which we all know about from our histology days in second MBBS. In addition to that, you can see that now we have other modalities to help us to decide which type of lymphocytes these are. And if we stain them, you will see that they take a strong CD3 stain, suggesting that they are T lymphocytes. Now, as I went on, you will notice that in the first picture, the number of cells were lesser as compared to the second. And in the third, you can see that almost the entire area is occupied. And so we have a gradation depending upon the amount of tissue occupied, wherein it could be less than 25 to 50%, and more than 50%. The next lesion we like to look out for is whether these lymphocytes, which are these type of cells here, where you just see these round nuclei, are they going into the lumen of the tubule? You can see the tubule here, which is highlighted by the PAS stain, thanks to the basement membrane taking up this stain. And you can see that in addition to these lining epithelial cells, there are these other small cells without any cytoplasm, which have entered into the lumen. And I can count them as 1, 2, 3, 4, 5, possibly 6, 7, so 8, so I know 9, so that I know that I have definitely more than 4 lymphocytes in the tubular lumen. I have to search elsewhere to see whether they are crossing the number 10 limit. And this is again just to grade the disease as to how much is the involvement of the tubular lumen. And this is what we call as tubulitis. So the first thing we had was interstitial inflammation with the T lymphocytes, and now involvement of the tubular lumina. The third component that is present in the biopsy, of course, is the glomerulus. And as you can see here, even without having any exposure to histology, you will realize that there are definitely a greater number of cells which are present within the capillary lumen. And we know our ratio of 1, 2, 3, where we are allowed only 2 endothelial cells in the capillary lumen. Here you can see that this entire lumen is occupied and there is no space left behind other than this one small area. And if you go on higher power, you will see that these are again small lymphocytes most often, but you have to understand that along with the lymphocytes, you can get a pleomorphous population of eosinophils, and you'll have to look out for the presence of the plasma cells, because plasma cell associated infiltrate has been shown to have a slightly poorer prognosis. At electron microscopy, you can see this is the endothelial cell, this is the basement membrane, and this is the epithelial side where you can see the foot process. And you will see that there is a definite separation that has taken place between the 2 layers of the lamina densa, and the normal organization of the lamina densa in the center, the rara externa and rara interna, is not seen. There is a vacuolated area present, and this has been also replaced by some granular material. And this is what you will see in the rejection of whether it is T lymphocyte or humoral rejection. This is the glomerulus on low power, and you can see that you can barely see the capillary loop. This is an entire loop. No lumen is seen except for a small lumen here because it has got itself occupied by all kinds of cells, basically lymphocytes. So here we have another lesion that you see in this kind of rejection, which is a glomerulitis. So just to revise, you get interstitial inflammation, tubulitis lesions, and glomerulitis. You can give a diagnosis of T-cell mediated rejection, keeping in mind that your interstitial inflammation has to be more than 25%. The number of cells present in the tubular lumen have to be more than 4. Once these criteria are met, you can give a specific diagnosis of T-cell mediated rejection. So this is just a tiny little study we did just to let you know that in addition to the T cells, the B cells marked by CD20 are also seen. But generally, we found that in our data, we didn't have any significant poorer prognosis taking place when you had a mixture of T and B cells. But CD138 marks the plasma cells, and the moment you have plasma cells coming in, then the prognosis alters and the patient starts presenting with significantly higher creatinine, very difficult to bring it down. In addition to these, the vessels have also to be looked at, and hence my insistence that I need 2 vessels before I can comment on the presence of vascular involvement, because that immediately changes our grade from 1 to 2. And what is it that we are looking for? You are looking for the lymphocytes being present just below the endothelial cells as the first opening criteria for you to call it as an endothelitis. It may not remain limited to that. It may come into the muscle and move out. But most often, when you're dealing with a T-cell mediated rejection, it remains at that level and does not progress. This lesion where I have a fibrinoid necrosis taking place is extremely rare, but not that it has not been described in T-cell mediated rejection. But in these days where we are so aware of what's happening, these lesions have become very far and few in between. What is extremely important for any person who is looking at the biopsy or reading the report is to see whether we have interstitial edema, because once you have interstitial edema, you know you have to search for the presence of a rejection, be it T or B cell mediated, antibody mediated. And in addition, you may get markedly congested glomeruli. They do not connote any specific diagnosis, but the moment you see these 2 features, it means that more work needs to go into the biopsy to specifically look to evaluate the presence of rejection. And most often, the vessel to be involved by the endothelitis lesion is a large-sized vessel, which in our kidney biopsies actually only those that come near the arcuate regions. So this is just a summary of what I've already mentioned to you, and I'm going to move on now to let you know that when it is type 1, it is limited to the tubulointerstitium, very easily looked after. When it comes to the endothelitis level, which is type 2, and that is what I told you, needs the presence of the vessels, the survival drops down. And when it goes to 3 with the fibrinoid necrosis, the response to treatment is also very guarded. Just to give you this is available anywhere. This has been done by the BAF for the simple reason that now you can grade it to A, B, so that you know how much of therapy needs to be given. As we move on, if the biopsy has been done a little later on, where the patient has been well preserved, but has now come late in the course of the disease, you will find, not in the course of the disease as much as in the transplant, you will see two features that are seen over here. One is changes of chronicity. As you can see here, this is a glomerulus showing sclerosis. And you can see here that these tubules have shrunk to 50% their size and have got a thick basement membrane, suggesting tubular atrophy. So telling me that changes of chronicity have crept in, but out of proportion infiltrate with lymphocytes, showing me that I also have an additional active component to the chronic changes. And so this earns the label of a chronic active T-cell mediated rejection. Here, important for you to see the changes of chronicity. You can see the fibrosis here in the interstitium, periglomerular fibrosis around the glomeruli, thickening of the blood vessels, and tubular atrophy. And this inflammation, the inflammatory cells or the T lymphocytes are seen both in the non-involved area. By non-involved, I mean where chronicity changes are not seen and where the chronic changes are seen. In a routine biopsy, if I have to give a diagnosis of an active lesion without chronicity, this infiltrate cannot be noted in the areas of chronicity for me to call it as a pure active lesion. The vessels also take their brunt, and you can see that there is fragmentation of the internal elastic lamina, and there is a new lumen that forms because of the inflammatory cells, mainly the histiocytes and the fibrous tissue. And that, of course, need not be there for the diagnosis. Again, BAF has helped us with the grading, and once you see the grading, that will tell you the prognosis of the transplant. Now, this is a change that I used to see about maybe 10 or even 12 years ago, which luckily for me, I have not been seeing. And just to show you that you can see this kidney flabby, completely replaced by hemorrhagic material, not showing the nice, smooth, brownish texture that we would all like to see. At histology, you will see engorged glomeruli showing fibrin material staining very nicely with fibrinogen at immunofluorescence. And this is hyperacute, or in the earlier days, what we used to call as hyperacute rejection. And our real hyperacute rejection has been seen only in 2010. Does not mean that it is still not occurring. Very, very rare occurrences have been known to occur. Now let's move on to the next type of rejection, which we're now seeing fairly often because we are doing transplants across both the HLA and the ABO groups. And what is the first histology item that you have to look out for are the presence of these neutrophils. We all know how to recognize a neutrophils because they have 3 subdivisions of their nuclei and a clustering of these neutrophils around a small little empty space, which is the peritubular capillary. Neutrophils can also be seen in the T-cell mediated rejection, but they are far and few in between, and they can also be seen in infective lesions, but we are aware of those because we have other things happening when the patient has an infection. Higher power view to just show you that these are all neutrophils and they are mainly around this small little peritubular capillary, and that's where they are present in all the regions. Just to highlight the neutrophil, and you can see that it is moving now into this peritubular capillary. So this is a peritubular capillary, this is a neutrophil, and you can see here that it is now moving into transgressing into the peritubular capillaries. So our first feature is that you must have neutrophils. Second, the neutrophils should transgress into the peritubular capillaries, and identical glomerulitis, which I showed you in the T-cell mediated, sometimes associated with increased number of neutrophils. At electron microscopy, same picture you will see markedly wide and lucent areas in the lamina densa and increased number of cells and swollen endothelial cells. In addition, in humoral rejection, definitely you will see the presence of fibrin-like material in the small-sized vessels, which I've shown you with a special stain over here in even the medium-sized vessels. Here you can see the fibrin material even at the HNE level with the lymphocytic infiltrate. Likewise, that you can see here with the fragmented red blood cells, causing secondary infarction in the neighboring cortical tissue. Again, markedly wide interstitium and showing that there is complete absence of the tubules in this place, suggesting originally in my time, tubular necrosis, but now because in every scenario we cannot demonstrate this, you stay with tubular injury. In addition, the efferent arterioles may show you the hyaline material or the fibrin and mesangiolisis, which was originally thought to be the only diagnostic criteria for a TMA, but now we can even see it in, or has been now definitely shown to be a criteria for a humoral rejection. A higher power view of that, can you see breakdown of the mesangial, so that you just have these huge dilated capillary loops filled with fibrin, which is mesangiolisis. So mesangiolisis, congested vessels, congested glomeruli, definite changes in the vessels. You can see here myxoid change, fibrin-like material, and vacuolization of the lamina densa. Sometimes medium-sized vessels also show the fibrin material almost as if it is forming a thrombus, and all these put together give you a diagnosis of active humoral rejection. We now know that only histology is not adequate for us to come to this specific diagnosis, and so therefore we have to show the presence of C4D in the peritubular capillaries. And please note, it has to be a linear diffuse staining, which you have to have it present along with a positive control. And this can be seen with the help of immunohistochemistry, sometimes far better seen with the help of immunofluorescence, with C4D incubation, of course. There are scenarios wherein C4D may be negative, and yet you have a humoral rejection for which you have to have the presence of your serology of a DSA positivity. Why? Because TMA can show you an identical histology, and you have to know what you're dealing with. Maybe in most scenarios, your treatment modalities are almost similar, but yet for the outcome, you have to know whether you're dealing with an acute humoral, active humoral rejection or a TMA. So it's a package deal. You need your clinical features, you need your histology, you need your C4D, and you need your DSA before you can come to a specific diagnosis. And this, therefore, is an extremely important criteria which has to be taken into account along with the presence of DSAs. BAF, of course, has helped us to classify it. And these are the histology classifications which are put out once you have the C4D and DSA levels. What is very important to remember is that if you have histology and you have a documented DSA, you can still come to a diagnosis of a humoral rejection without C4D, which can be negative, because at the end of the day, that's just an end result that we are seeing, which has just by serendipity come positive in your humoral rejections. So just the classification by BAF, now it has been seen that we have a fair number of patients who are showing a TMA-like lesion and some patients who just come with tubular injury. Most often, if the cadaver kidney has been well preserved, then the amount of tubular injury is lesser. But in some scenarios, if the time has been a little in excess, then tubular injury can be even seen without a rejection. And so it has been thought that some gene transcripts to show us the presence of specific endothelial injury may be required in future. I don't think they still have come out in, just the market for everybody to perform, but trials are ongoing. But I stand corrected because I only talk about India. I don't know really and I can tell you about Mass General, but about the rest of America, I'm sorry, I won't be able to comment upon. Now, in addition to your changes of tubular injury, the vascular involvement of the glomeruli, you also get a arterial involvement, but generally it has been found for some reason involvement of endothelitis-like lesions is less seen in the humoral rejection as compared to a T-cell mediated rejection. And there have been biopsies where you do not see the classical changes of a T-cell mediated rejection. You do not see the changes of humoral rejection, but you definitely see endothelitis. And then it has been thought that just because of statistics, you first veer towards a T-cell mediated rejection, do your C4D, do your DSAs, and if those come negative, then stay with the diagnosis of a T-cell mediated rejection. Moving on to the chronic changes that can happen with the humoral rejection, the commonest being the transplant glomerulopathy, and the diagnosis is made only when you see a definite space between the capillary loops, where normally your capillary loop has to be thin, almost as a single line. And here you can see that a split has taken place with vacuolization in the center, which is very well documented by the silver stains. I'm sorry, unfortunately, I did not have a Mason, and my teacher, Dr. Colvin, gave me this slide, and you can even see it on the Mason stain. But in our hands, our silver is working so well that I do stay more often with silver than with the Mason. And you can see the marked widening that has taken place at electron microscopy. This being the outer end, you can see the foot processes. This being the inner end near the endothelial cell, and the wide lamina densa filled with granular material. I have to specify that TMAs can show you identical appearance, and so can cyclosporin toxicity in some scenarios, but most often that is secondary to a TMA-like picture. And so therefore, if in addition to that, you have a nice C4D positive staining occurring along the glomerular capillary loops, you can specify that this is probably the end result of a repeated active humoral rejection and not a T-cell mediated rejection, which also sometimes results in a transplant glomerulopathy, but far lesser than the humoral rejections. Moving on to chronic changes, as you can see over here, this glomerulus is almost going into sclerosis. Here you can get sclerosis all diffuse like you're seeing here, or it may even present to you as an FSGS lesion. And these changes are secondary. This is not a primary FSGS, which you worry about that, oh my God, have I got a recurrence? But this, depending on the time profile and by looking at the other glomeruli, you can decide whether this is a primary FSGS or a recurrence of a known patient having FSGS in the pre-transplant days. This is secondary to a humoral rejection or a T-cell mediated rejection, and come as a cyclosporin toxicity lesion. In some cases, in addition to the glomeruli taking the stain, you can see even the peritubular capillaries have shown a proper deposition of the C4D. In some scenarios, in these kind of patients, the DSAs may not come strongly positive, maybe negative, or maybe just weakly positive. But the presence of C4D positivity suggests that the complement is being utilized and is being left behind over there, that some active component is present. And then I think the clinician has to wait whether, depending upon the chronic changes, whether you do need to become a little aggressive to treat the active component or not, because in any case, they have their own problems of treatment with these. Again, just to show you that in addition now to this vacuolization, there is something else that is happening over here, just the earlier changes. And if I show you the next slides, you will see that there is increased layers of the outer basement membrane-like material that are being formed. There's not really a consensus. Some institutes are talking about 5 layers, some are talking about 7 layers. Even in the BAF, there is a little sort of problem, but that is for gradation. Once you see this, you know that you are dealing with a chronic lesion. And so then whether it is chronicity at stage 1 or stage 2 or 3, I think it becomes a question, a little bit of semantics, because once this chronicity changes in, no treatment is going to work. And hence the importance of doing the electron microscopy right at the initial stages, because if these changes, you can see here, this is an endothelial cell. If you see such amount of swelling of the endothelial cells, and if you see a few regions just showing maybe a questionable increase in the number of basement membrane-like material, circumferential areas, then you can suggest that early changes of chronicity are set in. Some studies have come out showing that if you do become a little aggressive with the treatment, these changes have been sort of kept at that level like an adipocere and not allowed to progress, giving a little longer time for the transplant to be present. Of course, again, the vascular changes are identical, but now you can see that in addition, the chronic changes have set in. You can see the amount of increase in the number of concentric lines that are forming over here, suggesting that these are acute lesions and these are the chronic lesions, but they definitely come in. And with progression, you will find that you get the vasculopathy, which first starts with laying down of the fibrous tissue, and new layers and new lumina are being formed over here, like you're seeing over here. And in addition, the presence of foamy cells, which you can stain and show that they're all histiocytes. And once this stage is reached, of course, I mean, we don't need to wait to know this because your creats are going to go up, then there is no hope for this transplant. And so therefore, we have to be able to decide between activity and the chronicity before we can do any form of active treatment. And not to say that hypertension does not come and play a role in these scenarios, because what has been 100% seen is that the moment you have vascular changes, even of early chronicity creeping into the transplant, by and large, these transplants do not do well, whatever be the treatment. And features of chronicity are hastened as compared to another transplant which does not have these. I'm just going to take a minute to just talk about this, because though, of course, we do not do surveillance biopsies, but what is important to note that in your standard acute antibody-mediated rejection, it's invariably apparent at clinical, the creatinine levels are going to go up for sure. You do have either changes of tubular injury, or they can even be seen greater lesions of thrombi, the neutrophils around the vessels, and the vascular lesions. C4D is always positive, diffuse, and DSAs are high. So in a case where C4D is negative, even if you have these three, clinical, histology, and the serum levels of DSA, a specific diagnosis can be made. It is these that we worry about because your serum DSA levels could be very low. Your C4D is not what a pathologist is happy to see. Nice circular rings of, well demarcated peritubular capillaries, just one area somewhere positive, and then you're always in a dilemma. And clinically also the patient is doing well, but not doing well. It is thought that it is this level that we need to catch because this is still an active antibody-mediated rejection. And whether then in this scenario, it is necessary for us to do the EM to show changes in the endothelium, be it at the glomerular level or at the peritubular capillary level. Of course, when we reach the stage of chronicity, then it's just the percentage of chronicity that we have. And then we're not really worried about how strong the C4D is and what's happening with the DSA. And I'm just going to stop with this because this always fascinates me. This was one of the first transplants done. You can imagine it's done in 1960. And till 2011, after that, when I follow up these, there's no mention of this. So I presume that, they're not now, doing well or whatever. But 5 decades, these 2 sisters who were twins, of course, so they mustn't have had any issues with their cross matches and all. They don't specify whether they were identical twins or what, but they did well for 5 decades. And I think that's what we're trying to achieve. We've reached very close to it. And so let's hope that with all of us, not being, of course, now, but all our younger colleagues who are doing so much of research, we do reach a stage which is better than this. So thanks so much.
Thank you, Shaila.
Not at all.
I can add to the last slide
Huh?
that these 2 sisters were identical twins.
Oh, okay.
And they had to go through a lot of legal hassle.
Yes,
because
that I read.
both were only 12 years old.
Yes.
And the law would not permit someone under the age of 18 to donate.
That's right. So the judge really took them through the entire spiel before. Yes, I know that. That I know. Yeah.
That was a very interesting story.
Yeah.
So again, fantastic presentation as usual. I will start off with one question.
Yeah.
That you showed one slide of chronic active T-cell mediated rejection.
Yeah.
A lot of tubular atrophy and interstitial fibrosis. If you are interacting with the clinician, in your opinion, would it be worth treating them or not treat them?
Yeah. So like I said, I would advise the clinician depending upon the amount of chronicity I have. If my chronicity is within that 1/3 level, then I would say that there's never any harm in giving a treatment to the patient for the simple reason that our T-cell mediated rejection treatment, well, it's not very, it is bad for the patient in the sense you're giving, but it's relatively lesser than what we are doing when it comes to humoral rejection. So if my chronicity level is less than 25 or 30, up to 30%, I would advise, because then you're at least prolonging your transplant that much more.
I have one more question, that in ABO incompatible transplants, we do find C4D positivity.
Oh, yes.
Without any injury.
Absolutely.
Any explanation for that?
Well, they used to call it accommodation in the past. And they thought that some amount of antibody-mediated, activity is happening, or that the complement is being utilized in some which way. But to date, nobody has given us a proper explanation as to old-time accommodation or new-time C4D positive without rejection, which, if you ask me, is just splitting hairs. No paper has come out to give a definite reason as to why this is happening. but it is very well documented. In fact, we use it as our positive controls, and in which case then I know in Mumbai it is very difficult to do DSAs, it's very expensive. If you have a cadaver also, it becomes even more difficult, in which case then we have to fall back only on two criteria. If we have definite, if it is at the stage of just tubular injury, then the clinician really has to hunt that why do we have tubular injury. And the problem in this scenario is that all our cyclosporin inhibitor drugs, toxicity is going to take place and your tubular injury is going to happen. So just simple tubular injury, I would just wait a bit before we initiate the treatment, where we have C4D positive thanks to the ABO incompatible, and our DSAs are very, not just maybe marginally elevated. If I definitely have peritubular capillary involvement with the neutrophils, with transgression, and I have excluded that I have no features of a T-cell mediated rejection and no features of infection, then I would definitely look at it as a very strong pointer towards humoral rejection and see my DSA levels. If again I'm stuck where I have a cadaver where I just can't do it, well, maybe I would look at some form of treatment depending upon how the patient is also doing clinically. I mean, you have to balance both these things. And lastly, if I have a definite glomerular involvement along with a vascular involvement, and I am sure it's not T-cell mediated, where then I would spend the money to do the CD3 to see that there is no tubulitis or a T-cell mediated infiltrate, then I would go towards a humoral rejection, because we still can treat our early humoral rejections properly, and then we are again giving more time for our transplant. So I would say that I would look at it from this approach if I cannot have the help of C4D.
So Shaila, Shruti can tell you that we have an immunology lab where we provide for DSA at any time.
I know that.
We have a 24/7 service, so we are attempting to do all cadaver HLA typings, including hearts, hand transplants, pancreas. So even in our team, whenever we have a deceased donor transplant, we do collect the donor EDTA bulbs and keep, so that later on I have the DNA to process the HLA. We make it a point.
Correct,
So
I know that.
going ahead, we are more wiser.
And secondly, Shaila, although it may sound that DSA is expensive, when you use treatment for acute antibody mediated rejection, which comprises of plasma exchange and intravenous immunoglobulin and rituximab, that becomes too expensive. So it is,
yes,
it would be wise to do the DSA and decide on that treatment, which would also add to your immunosuppression.
So I always go with the algorithm that, pre-transplant for all our deceased donor recipients and our living donor recipients, every 6 monthly, we try to do a PRA so that we know if there is anything which is positive. If something flags positive, we ask them to do an SAV. But we explain to the patient that going ahead, this is going to be more helpful to you because the treatment is going to be more costly.
absolutely.
Then it justifies the cost. And the PRA screen is hardly 6,000 to 7,000. Doing it is not as costly as treating a rejection if you come across a positive PRA.
The other thing is the importance of sequential PRA.
In fact,
Madam,
in fact,
I think you are muted, Shaila.
oh, good heavens. Sorry.
Now we can hear you.
Now we can hear
you.
Okay, sorry. All I'm saying is that in standard operating procedures, along with the clinical features where I must know the time of the transplant, I must know the clinical features, the DSA or any antibody levels that are present must come even as the biopsy is coming to you, because
exactly.
then only.
Exactly. When I report any HLA report, I ask for all clinical features. We spare no efforts to call patients, to call clinicians, to ask for the clinical details.
I know that.
I can correlate and give it.
Absolutely, because I mean, that's how it is at this stage. We do not have any other molecular markers.
Well, thank you so much, Shaila. I pulled you out from your daughter's birthday celebration, and I thank you so much.
No, not to worry. Not to worry.
For
Thanks.
joining us for this program at a short notice. Thank you so much.
Thank you, Bharat. Thanks for calling me. Good to meet you. Bye.
So friends, I told you that this is a very clinically oriented program that we planned. We had initial presentation by Dr. Shruti about immunology and immunological evaluation of a transplant patient. Then we had a presentation on the induction immunosuppression. Then we had presentations on maintenance immunosuppression and how to adjust the maintenance immunosuppression depending on the efficacy and morbidity. An excellent presentation by Dr. Vikas. Unfortunately, we don't understand the immune system so well. Acute rejection can develop, and how do we manage that? So to tell us about treatment of acute rejection, we have Dr. Prashant Rajput, who will tell us about both acute cellular and antibody-mediated rejection. Over to you, Prashant. Dr. Prashant is a senior consultant nephrologist and transplant physician at Global Hospital, and he has an experience of more than 500 kidney transplants, and he will tell us about how to take care of acute rejection.
Hope the slides are visible.
No. We are able to see your dashboard, not. Yes. We can now see if you can put it in presentation mode. Can you put it on presentation mode?
Yes. Is it visible now, sir?
It is visible. Now it's fine. Perfect.
Good evening, friends, colleagues, and teachers. And today I'm presenting about acute rejection, both acute cell-mediated and acute antibody-mediated rejection. We will start with the basic introduction of immunology of rejection. We'll discuss about cases which taught us about the rejections and some aspects of management and therapeutics of rejection. We start with the introduction. We know that whenever we have a transplanted organ, the principal target of the immune system is the MHC, which is expressed on the donor cell, basically the donor endothelium. This donor endothelium, which has the MSC, is the antigen is processed by the antigen presenting cell, which is the dendritic cell and the macrophages. And these processed antigens are then given to the CD3 positive T cells. And this CD3 positive T cells takes this antigen with the antigen presenting cell or the stimulated T cell would go into the regional lymph node, and this would produce a clone of cells. So when you look at the various responses of these T cells, as far as the transplantation is concerned, the basic augmentation of the immune response is by the Th1 cells, and this is facilitated by the IL-2. And this cell then produces IL-2, interferon gamma, and the TNF, which takes care of that leads to the rejection episode. Very small part is by the Th17 cells.
What is the problem, Vipul?
Sir, Prashant sir, net must have gone down. Internet.
The problem is with his net connection.
Yes, sir.
Then
Sir, he will connect back in a second.
produces the plasma cells and the
your
antibodies.
slides are not seen, Prashant. You'll have to share again. Should Prashant exit and then retry?
Yes, sir. Sir is doing that only, sir.
'Do you have a problem with the net connection, Prashant?
No, so net connection is stable.
You are muted.
Is this visible, sir?
No, your slides are not seen. Yes, now seen. Now well seen.
Yeah. So this is into the germinal center dependent, and that's the of
You are still at your original slide, the
differentiation
title
of
slide.
cells, and then eventually leads to antibody. So when we look at the outcome, 65%.
So, Prashant sir, this is Vipul here. Prashant sir, Vipul here. We are not able to see your screen. Sir, your internet is not stable. Prashant sir, your internet is not stable.
Can you use your cellular network for internet if your Wi-Fi is not stable?
Just a minute, I'll just. Yeah, is it visible so now?
No. Yes.
Yeah, I'll start from the beginning only.
Okay.
I'll start with the basic introduction. Then I'll take you through cases which taught us and some aspects of management and therapeutics in the management of rejection. The As far as the organ transplantation is concerned, the principal target of the immune system is the MHC, which is expressed on the donor endothelial cells. And this MHC is processed by the antigen presenting cells, which is the dendritic cell and the macrophages. And then it is presented to the T cell, which comes into the graft. This activates the T cell, and this activated T cell goes back to the lymph nodes, where it causes cloning of the T cells, and the clone of cells then come back to the graft, causing a rejection. When you look at the various various functions of the T cells, the major antigen responses is through the Th2 cells, and then partly by the Th17. The fate of the T cells, it's either it leads to exhaustion, or there is an accelerated immune response. Some of the T cells become antigen specific. These are the antigen specific Tregs, and they are also responsible for infectious or immune tolerance. When we look at the T cell, these T cells also cause the stimulation of the B cell, mainly in the extrafollicular germinal center of the lymph node, where they get transformed into the plasmablast and the memory B cell. And eventually, this plasmablast leads to an early response in form of the antibody production. The part of these activated B cells in the extrafollicular part of the lymph node, they get causes stimulation of the B cells in the germinal center, and that leads to secondary immune response in form of memory B cells and the antigen specific plasma cells. Then this activated T cells also stimulate the germinal center B cell, which through co-stimulatory pathway, and this leads to production of plasma cell, which leads to late immune response. When we look at the various causes of graft loss, it has been seen that about 65% of these patients eventually develop antibody-mediated rejection, that is chronic ABMR. Very few are missed rejections, and this is the major reason for loss of the graft. We come to the cases. The first case is a 31-year-old female. Her primary disease is glomerulonephritis, which is IgA nephropathy. The donor is her sister, and this is a second transplant. And she lost this graft after 10 years due to chronic allograft nephropathy, and the initial donor of this patient was her mother. It's an ABO compatible transplant. It's a haplo match, and the CDC cross match is negative. This was a transplant which we did a few years back, and at that time PRA screen was just available, and the PRA screen at that point was negative. The induction immunosuppression was solimedrol 500 milligrams, and antithymocyte globulin was given 1.5 milligrams per kg at the time of transplantation. Post-op, the kidney was pink, but there was no urine output. Uh, this patient, after a few hours, became hypotensive. The pulse went up to 120 per minute. She had severe pain and tenderness at the transplant site. The Doppler done at that point had no perfusion. She was re-explored, and this kidney looked pink. This kidney was blue. Eventually, it was explanted, and possibly this was a hyperacute rejection. When we look at the time frame of rejection, the initial within 24 hours, if you develop a rejection, it is nothing than a hyperacute rejection, and this is a severe form of antibody-mediated rejection. It was observed that when a kidney is transplanted into a recipient with a pre-existing DSA, that leads to hyperacute rejection. So in our case, the recipient developed a hyperacute rejection in spite of a negative CDC, a negative PRA. Probably she had a very low level of antibodies, which was missed on a CDC cross match. And since the sister and the mother shared, I think, a single antigen, so probably she had a DSA to that specific antigen, and this patient eventually developed hyperacute rejection. So this phenomena was first published by Patel and Terasaki in 1969 through their seminal paper in the New England Journal of Medicine, where they showed that 24 of the 30 patients with a pre-transplant positive cross-match had immediate graft failure, compared to only 8 graft failures of 195 patients with a negative cross-match. And this is a very, very significant observation, and this was the basis of the most important test as far as transplantation is concerned. So hyperacute rejection can also be caused by antibodies directed to allogenic blood groups A and B. In our experience of ABO incompatible transplants, we have not seen even a single patient developing hyperacute rejection because of ABO antibodies. The second case, this is a 36-year-old male. His primary disease is chronic glomerulonephritis. This is a preemptive transplantation. This patient has no sensitization history. The donor is her stepmother. The HLA mismatch is 5/6 HLA. The CDC cross-match done that time was a negative CDC, and the flow was not available at this point. The induction immunosuppression was methylprednisolone 500 milligrams and ATG 1 milligram per kilogram for 2 days. The patient was started on immunosuppressants, tax and tacrolimus and MMF at least 2 days prior to the transplant. This patient had a prompt allograft function. At day 4, the serum creatinine was 1 milligram per deciliter. On day 5, it increased to 1.1, but patient became hypertensive. He was oliguric. The tacrolimus trough level was about 10 nanograms per ml, which was also okay. The Doppler showed slightly reduced velocity, and the peak systolic velocities were slightly on the lower side. There was no renal artery stenosis. There was no renal vein thrombosis. There was an absent diastolic flow, which suggested that probably there was a significant interstitial edema. An allograft biopsy was performed, and this histology came back to us as changes of ATN, and there was a C4D which was positive. The patient required hemodialysis because the potassium was about 7. We treated him with methylprednisolone 500 milligrams stat, and it was given for the next 3 days. The patient was immediately taken up for plasma exchange, and a single volume exchange was done on alternate days for about 5 sessions. And after each session of plasma exchange was followed by 400 milligram per kilogram of IVIG. This patient also received rituximab 375 milligram per meter square body surface area after the first PP. And on day 15, the patient was discharged at a creatinine of 1.3. So this was an acute antibody-mediated rejection. As per the current 2013 BAMF classification, the 3 cardinal features of AMR is a positive C4D staining or increased expression of endothelial activation injury transcript, that is NDATs. You need to have a circulating DSA, and you need to have an evidence of tissue injury. If this patient was today, we would get the DSAs at a record speed, and even before we do the biopsy, we collect the sample and we send it for a single antigen bead assay for class 1 and class 2 antibodies, and we get the report within hours, and we can establish the diagnosis of AMR. So what is the pathogenesis of AMR? Usually you have a sensitization history, either a blood transfusion or a previous transplant or pregnancy. This is responsible for the activation of B cells. The B cells get differentiated into plasma cells, and these plasma cells produces alloantibodies, which are complement fixing. And once you have an activated complement that produces the anaphylotoxins, causes recruitment of the NK cells, monocytes, and neutrophils, and that is responsible for the graft. As far as the therapeutics are concerned, rituximab works on the B cells. You have a significant suppression of the T cell and B cell by mycophenolate. mTOR inhibitors and calcineurin inhibitors are very, very effective against the T cells. As far as the plasma cell is concerned, bortezomib is the drug, which is a proteasome inhibitor, and it specifically acts on the plasma cells. The antibodies are taken care of by using plasma exchange and the IVIG. The complement activation can be taken care of by C1 inhibitor, which is and eculizumab, which works at the C5A. As far as the therapeutics of AMR is concerned, the AMR, an early report of 5 patients with AMR with peritubular capillaries with C4D treated with combined with plasmapheresis and conversion of tacrolimus and mycophenolate showed reversal of AMR in all 4 cases. These patients also received low dose IVIG and OKT3, and the graft survival at nearly 20 months was about 100%, and the mean creatinine concentration was about 1.4 milligrams per deciliter. Just a minute. What is the treatment of AMR? This is the KD guidelines. We suggest treatment of acute antibody-mediated rejection by following alternatives with or without corticosteroids, using plasma exchange, IVIG, anti-CD20 monoclonal antibody, which is rituximab, and lymphocyte-depleting antibody, which is alemtuzumab. For patients who have a rejection episode, we suggest adding mycophenolate if the patient has not received mycophenolate or azathioprine, or switching to azathioprine to mycophenolate mofetil. As far as the IVIG is concerned, this is the most commonly drug used along with the plasma exchange and rituximab, routinely used as a high dose regimen of 2 grams per kilogram divided into 5 doses. The low dose regimen uses 100 milligrams per kilogram per session. The low dose IVIG is mostly used in combination with plasma exchange, where it may help to replenish the depleted IgG. The initial studies use IgG at higher doses without plasma exchange and described a fair degree of success in desensitization prior to transplantation and certain patients with treatment of rejection. As far as the side effects are concerned, aseptic meningitis is a common side effect, volume overload and AKI because of the osmotic injury when the vehicle of IVIG is sucrose based. So you need to be very, very careful as far as the IVIG is concerned, and especially in the post-transplant setting where you can have an AKI. The second drug commonly used is rituximab. The mab in AMR is not clear. However, it is the action is on the CD20 positive B cells, and these cells are completely wiped off for many months, and there is a significant decrease in the antibody generation. The rituximab does not act on the memory cells. It does not have effect on the antibody producing plasma cells. The main side effect of rituximab is infusion reactions. You need to be very, very careful. You can end up having severe hypotension following rituximab. You can develop a press-like syndrome with rituximab, especially in children. Reactivation of latent viruses such as hepatitis, CMV, and TB is common. Core antibody of all patients who are to receive rituximab because it significant effect. As far as the
Your net connection again is poor.
combinations are concerned, the best combination is 2009 with a IVIG. So this was a study of diseased donor kidney transplant. The patients were proven to have AMR with positive DSA, a negative current CDC cross-match at the time of transplantation. All these patients had received thymoglobulin, the standard immunosuppression of triple drug with steroids, with Celcept and tacrolimus or cyclosporin, and patients with remote positive, the IgG T cell or B cell cross-match also received IVIG at the time of transplantation as a part of
Your net connection
prophylaxis for acute rejections, and they received 2 grams per kilogram. So this was the basic outcome. The graft survival at 36 months, it was 91% in group B, which was a combination of plasma exchange IVIG, and it was 50% in group A. The conclusions of the study, the plasma exchange IVIG and anti-CD20 had a superior survival over IVIG alone. Grafts better with the combination, and there was a significant diminution of the DSA of these patients. Bortezomib, which is a novel proteasome inhibitor, it is approved for treatment for multiple myeloma. This drug inhibits the proteasomes, which can lead to a decreased nuclear factor kappa beta activation. It causes cell cycle arrest. It causes endoplasmic reticulum stress and increased cell apoptosis, mainly of the plasma cells. Its action is predominantly on the plasma cells and of the cells which have a high antibody turnover and a very high endoplasmic reticulum activity. So this was a regimen of AMR of 2-week cycles, which included bortezomib, and this the plasma exchange cycles were twice weekly, total 4 treatments given on day 1, day 4, 8, and 11, and each session of plasma exchange was followed by bortezomib treatment. all patients also received 2 gram per kilogram of IVIG of 0.5 um, gram per kg in 4 divided doses post the plasma exchange. What was interesting was the patient survival was 100%, the graft survival was 85% at the mean follow-up of 9.8 months. Eculizumab, it's a complement protein. C5 antibody inhibits the formation of the membrane attack complex. It was approved for treatment of paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome. There's a marked decrease of the membrane attack complex following the use of eculizumab, and there's a there are multiple reports where you have salvaged a severe AMR following eculizumab. In patients who are refractory AMR, even splenectomy helps to ameliorate the rejection. What are the experimental therapies? Immunoadsorption, use of alemtuzumab. One of our patients actually received alemtuzumab for treatment of AMR, where transplant was done elsewhere, and the patient had an excellent outcomes post use of alemtuzumab as a part of rescue therapy for treatment of AMR. The latest drug for treatment of AMR is the IDES, which is the IgG indopeptidase. This was a very interesting paper where they used IDES for desensitization, but I think this is a very, very promising drug as far as treatment of AMR is concerned, because that can significantly reduce the anti-HLA antibodies with a single treatment to negligible levels. So this is the new drug which is probably will replace all the treatments for AMR in the future, which is the IgG indopeptidase. The case 3, this is a 42-year-old female. She's married, and her primary disease is unknown. She underwent an ABO incompatible kidney transplant with a spousal donor. The pre-transplant titers was 1:512 IgG, which was an anti-B antibody. The pre-transplant immunosuppression included induction with rituximab 200 milligrams on day 7. The patient received 3 sessions of plasma exchange and was started on prednisolone 20 milligrams, TAC and MMF on day 7 pre-transplant. The pre-transplant titers was 1:16. The patient underwent a transplant and received simulated induction with methylprednisolone. There was an immediate graft functions. At day 4, the creatinine was about 0.6 milligrams per deciliter, good urine output, no hypertension, but the titers increased gradually to 5:2. This patient, we were in the dilemma of whether to do plasma exchange or no PP, and we decided that at least the titers were high. So we thought we gave her one plasma exchange, and there was no change, and the titers did remain come down to 256 and gradually climbed up to 5:2, and the patient continued to have a graft function. So this is accommodation. Accommodation is a situation where you have DSA, you have a C4D staining in the peritubular capillaries, but there is no evidence of tissue injury in the graft, and the graft function is stable. So this is a very, very important phenomena. This can happen not only in ABO incompatible transplants, but also in HLA incompatible transplants, and you can develop accommodation. And this feature of accommodation has been seen in patients who are treated with IDES, and it is a very, very interesting phenomena when a lot of things needs to be actually a lot of work needs to be done on the phenomena of accommodation. Case 4 is a 15-year-old male. His cause of end-stage kidney disease is unknown. It's an ABO compatible transplant. Mother is the donor. It's an haplo match and only 2 mismatches. He underwent a transplant in 2015, and the standard immunosuppression included TAC, MMF, and prednisolone. The pre-transplant trough level was about 9.3 nanograms, which was absolutely all right. Patient received steroid induction of 500 milligrams. He had an immediate graft function. Day 3, his creatinine was 0.75 milligrams per deciliter with an adequate levels of tacrolimus. On day 7, his creatinine jumped to 1.1. His blood pressure increased to 160 by 100 millimeters of mercury. He continued to pass about 5 liters of urine. He had no other symptoms. His urine was bland. His Doppler was normal. So this was the biopsy, which was an acute cellular rejection 1B, treated with methylprednisolone 250 milligrams for 3 days, and his creatinine came back to 0.75 milligrams per deciliter, and he was discharged, and this patient continues to do very well. As far as the therapeutics of the T cell mediated rejections are concerned, it is still corticosteroids. About 73% of patients receive corticosteroids. It is the first line therapy. The drug of choice is methylprednisolone, given at a dose of 3 to 5 milligrams per kilogram intravenously for 3 to 5 days. And you use a rapid taper of oral steroids. BANF 1A and 1B in the cooperative clinical trials and transplantation, it's class 1. The expected reversal rate following corticosteroids is about 60 to 70%. The response is seen in as an increase in the urine output and drop in serum creatinine within 5 days. If the patient is not on tacrolimus, switching it to tacrolimus, the resolution of rejection is seen about 93% as compared to 64%, and there is a significantly lower incidence of recurrent acute rejections in patients who have been shifted back to tacrolimus. As far as the complications are concerned, it is very, very important to note complications. There's increased susceptibility to infections. Special oral candidiasis is common following the treatment of with steroids. Acute hyperglycemia is a very, very common complication following acute or following pulse steroids. You can have a varying symptomatology for presentation. We have seen patients develop severe myoclonic jerks, including a continuous myoclonic jerks for days together, and this was found to have an acute hyperglycemia. Hypertension is common. Peptic ulcer is not that common, and you can often sometimes see psychiatric disturbances, and these patients need to be put on basically bisphosphonates to prevent bone disease, which usually occurs in 3 to 7 days. So what is steroid resistance? If you have a lack of improvement in the urine output, and if the serum creatinine does not come down by 5 to 7 days, this is a steroid resistant rejection. You need to then administer anti-lymphocyte antibodies, either polyclonal antibodies in form of thymoglobulin, OKT3, which is now not available, or alemtuzumab, which is available at some centers. The other thing which is important is you need to see what is the infiltrating cell line. We need to look for the CD20, the B cell rejection, and sometimes the CD68, which is a monocyte rejection, which has a poorer prognosis. As far as the ATG is concerned, usually it is we use the rabbit ATG. It's a polyclonal antibody. You use rabbits and horses with human lymphoid cells derived from the thymus, and you use the cultured T cell lines. The T cell depleting agents, they act on the peripheral blood primarily, and they cause complement dependent cell lysis, and which contains specific antibodies inhibiting the B cell proliferation, and including it induces the B cell apoptosis. You need central venous access. You need to either give it through the AV fistula if you have one. You have a primary treatment. The reversal rate is about 75 to 100% in days and weeks. Thymoglobulin is usually used in 1B, 2, and 3 BANF cases, and the dose is about 3 milligram per kg per day for 3 days, or 1.5 milligram for about 5 to 7 days, and the total dose should not exceed about 9 milligram per kilogram. The rabbit versus horse multicentral double-blind trials in 163 transplant recipients, acute rejections reversal was about 88%, and you had a lower rate of recurrent rejections in 90 days post the antibody treatment. Complications of ATG are fever with chills, anaphylactic reactions, you have thrombocytopenia, you have high risk of developing infections, mainly the CMV, PCP, and herpes infections. You have high chances of developing post-transplant lymphoproliferative disorders, and some patients may even get serum sickness. Alemtuzumab is a humanized anti-52 monoclonal antibody approved for CLL. The CD52 is expressed on the T cells, B cells, natural killer cells, monocytes, and macrophages. Treatment of acute rejection, it causes lysis of the lymphocytes via complement activation and via complement-dependent cellular cytotoxicity. It can be given through a peripheral vein at a dose of 30 milligrams, 1 or 2 doses. In the largest study of alemtuzumab, you had a reversal of acute rejection in about 63% of the patients. Infectious complications and prolonged cytopenias are extremely common. The steroid-resistant rejections are, especially with CD20 positive B cells, steroid-resistant rejections, the cellular rejections, you can use an adjuvant to ABMR, and you have when you look at these patients who had a long-term follow-up, there's a high chance of death with severe infections following use of alemtuzumab. The case 5, 18-year-old female, her primary disease is CACOT. She is on CAPD for about 4 years, transplanted in 2011. Donor is her grandmother, 2/6 mismatches. She had a CDC cross-match which was negative, no sensitization history. She had an immediate graft function. She was very difficult to control hypertension, about requiring 10 drugs and 30 tablets to control her hypertension. And she was taken to the OT with BP of 220 by 110. And just with the immediate graft function, the antihypertensive requirement significantly diminished, and her post-transplant creatinine came to about 0.4 milligrams per deciliter on discharge. In September of 2019, after 8 years, her creatinine gradually crept up to 1.4 milligrams per deciliter. She started developing proteinuria. She had missed medicines. We did an allograft biopsy. The biopsy turned out to be transplant glomerulopathy. We got her single antigen bead assay done. She had class 1 positive, and the C locus, the MFIs were about 15,000. She was initiated on IVIG, 400 milligrams per kilogram every 3 weeks. And such 5 doses were given every 3 weeks. And her creatinine came down to about 1.1 milligrams per deciliter. And the UPCR reduced to about 1.2, and there was a significant improvement. As far as the treatment of current outcomes of chronic antibody-mediated rejections are concerned, there's a very high chance of graft loss. The mean time to graft loss in this study was about 1.5 years. About 96% of the patients lost their graft, and the time to death was about 2.2 years, where about 25% of the patients.
Prashant, chronic is going to be dealt with by HAPL.
Yes.
So can
Yes.
you summarize now?
Yes, we are just summarizing.
Don't talk about this chronic antibody-mediated rejection.
So this is a last slide. This was basically based on the case, and this patient was treated with IVIG and steroids, and there was a significant resolution of the antibody-mediated rejection. And today, as far as the rejections are concerned, the acute antibody-mediated rejection, the prevalence is about 2% in our patient subgroups, and the cellular rejection is anywhere between 8 to 13%. And since we have been able to risk stratify patients, we have a significant reduction in the number of patients developing acute rejections. Thank you very much. And if there are any questions, we'll be very happy to take those.
So maybe we can take this in the end. We are running late. So I would now request Dr. Happel to give a presentation on treatment of chronic allograft nephropathy. It's not uncommon for patients to present after a few years of transplant with slowly deteriorating graft function. And how to approach such cases, Dr. Happel Vora will tell us. She is a pediatric nephrology at Institute of Renal Sciences at Global Hospital. But like Dr. Vikas, she also is involved in adult transplant program, and she's going to talk to us about chronic allograft nephropathy.
Good evening, everyone. Thank you, sir. I would like to start my talk on chronic allograft nephropathy. Chronic allograft nephropathy is one of the most common reasons for graft loss. About 35% to 40% of graft loss are due to chronic allograft nephropathy. It's also called as chronic rejection, transplant nephropathy, or chronic allograft dysfunction, or transplant glomerulopathy, or chronic allograft injury. Over a period of time, all these nomenclature has come. It is one of the most common cause of end-stage kidney disease, accounting for 25 to 30% of patients awaiting kidney transplantation, awaiting their second transplant. CAN is the result of immunological injury and non-immunological injury. So immunological injury has acute cellular rejection, acute and chronic antibody-mediated rejection. Non-immunological injury has multiple factors like hypoperfusion, ischemia-reperfusion, recurrence of primary disease, calcineurin toxicity, and infection. CAN is a histopathological description. So classification of CAN is histological using Bank classification of renal allograft and has classic findings of interstitial fibrosis, tubular atrophy, glomerulosclerosis, fibrointimal hyperplasia, and arteriolar halitosis. This is a pictographic presentation of various histopathological findings with their underlying etiology, like the tubular atrophy. It happens with ischemic reperfusion injury, rejection, acute severe or subclinical calcineurin toxicity, or a polyoma virus. The fibrointimal hyperplasia is a true chronic rejection, due to a donor disease and hypertension. Arteriolar halitosis, calcineurin toxicity, or diabetes. Interstitial fibrosis, ischemic reperfusion injury, subclinical rejection, calcineurin toxicity, and the glomerular abnormalities, primarily transplant glomerulopathy, that is chronic antibody-mediated rejection, recurrence of primary disease, and glomerulosclerosis. Now, how do we approach a chronic allograft nephropathy? It is like a chronic kidney disease. We don't have a specific set protocol or guideline to approach and manage chronic allograft nephropathy. We have to come down to the most probable cause of chronic allograft nephropathy and try to treat it. So it is going to individualize. Every case of chronic allograft nephropathy is going to be different, and the treatment is has to be tailor-made to each individual. What are the etiological factors? They are donor factors, recipient factors, acute cellular, acute and chronic antibody-mediated rejection, subclinical rejection, compliance to immunosuppressants, calcineurin inhibitors, and infections. So what are the donor factors? There are a number of donor factors associated with chronic allograft nephropathy, which include donor age, where extremes of donor ages do poorly, any pre-existing disease in the donor or any injury to the donor, degree of HLA mismatch with the donor, organ-specific issues such as prolonged cold ischemia time or a delayed graft function. Male donors have better outcomes than female donors, probably related to the organ size and nephron mass. Living related and living unrelated donors usually have better outcomes compared to diseased donors related to the ischemia, reperfusion, injury. Recipient factors. Young kids and adolescents, they may have more chances of chronic allograft nephropathy, mainly due to non-compliance to the medicines. Recurrence of primary disease, focal segmental glomerulosclerosis, atypical HUS, congenital nephrotic syndrome, IgA nephropathy, C3GN nowadays. Prior sensitization with previous transplants, blood transfusions, pregnancies, in which case PRA screening is going to help, and we can risk stratify the recipient with prior sensitization. Small recipient size transplanted with large adult sized kidney. This is mainly for a pediatric recipient who lands up receiving an adult donor kidney. Hypoperfusion of large kidney from a small sized recipient. So chronic ischemia and HLA matching with the donor. Acute and chronic rejection. Any rejection predisposes to chronic allograft nephropathy. How promptly the rejection is diagnosed, how promptly it is treated is going to be a major contributing factor for whether it is going to progress to chronic allograft nephropathy. The severity of rejection and the response to treatment is what is going to decide whether the chronic allograft nephropathy is predisposed. Chronic AMR. I would like to discuss a case, 48-year-old male, transplanted in September 2009. It was an unrelated transplant with stable creatinine of 0.9 milligram per deciliter until June 2017. His maintenance immunosuppressants were Visalone, azathioprine, and everolimus. From October 2018, the creatinine went to, 1.3 to 1.4 milligram per deciliter with nephrotic range proteinuria and acute onset of hypertension. With the nephrotic range proteinuria, everolimus was stopped and cyclosporin was introduced. In November 2018, the creatinine further increased to 2.5 to 3 milligram per deciliter with a worsening hypertension and proteinuria worsening to UPCR of 7 to 10. He was PRA class 2 positive. Transplant biopsy was done and was suggestive of chronic AMR with acute tubulitis. Single antigen bead assay was not done as donor HLA was not available. He was treated as acute with background chronic AMR, treated with methyl pulse solumedrol, rituximab, plasmapheresis, and IVIG. The whole IVIG, the whole treatment for a antibody-mediated rejection. The entire course was given with almost 5 sessions of plasmapheresis and total dose of IVIG going to 2 grams per kilogram. However, there was no significant improvement in graft function or proteinuria. Rather, a couple of months later, he developed a CMV pneumonia and had recurrent LRTI for subsequent 6 months, during which his graft dysfunction worsened and progressed to end stage, and he was initiated on dialysis. So with this case, I would like to highlight some points like chronic antibody-mediated rejection, which presents with nephrotic range proteinuria, severe hypertension, shows poor response to the entire course of treatment. Rather, immunosuppressing the individual predisposes him or makes him fall prey for many opportunistic infections. Going to subphysiological presence of immunoreactive cells within the allograft, suggestive of acute rejection without clinical deterioration of renal function. That is, the renal function remains stable. So this is generally picked up on protocol biopsies. which is performed in some centers. Untreated subclinical rejection can lead to development of overt acute cellular rejection with graft dysfunction, or may smolder onto an eventual chronic allograft nephropathy. This smoldering subclinical rejection is the one which is usually missed. And by the time the patient develops proteinuria and a graft dysfunction, it's too late to reverse the injury, and we have almost lost the battle. Compliance. Compliance to immunosuppressant, adherence to immunosuppressant is a practical issue, and mostly adolescents, because they are at that age where they will be, their attitude is going to be casual, less responsible, and being occupied with multiple other things. So they tend to miss knowingly, unknowingly the immunosuppressants, and otherwise individuals of any age group may tend to default with the treatment, leading to subclinical rejection and chronic allograft nephropathy. Recurrence of primary disease, chronic glomerulonephritis, IgA nephropathy, C3Ga. Many a times when a patient comes with a raised creatinine with shrunken kidneys, when we are not able to biopsy the patient to diagnose the native kidney disease, or is presented as at the end stage, where again we have lost the opportunity to diagnose the native kidney disease. However, in every case who's going for transplant, knowing a primary native kidney disease is definitely going to help us plan the immunosuppression and look for those issues. So here we have a 31-year-old male whose native kidney disease was a chronic proliferative glomerulonephritis. It was a biopsy-proven chronic proliferative glomerulonephritis. He underwent a preemptive transplant in March 2016 with mother as the donor. He stabilized at a little higher creatinine of 1.5 to 1.7 milligram per deciliter. The induction agent was solumedrol basiliximab, and the maintenance immunosuppressant were standard Visalone, tacrolimus, and mycophenolate mofetil. He developed hematoproteinuria by 3 months of transplant. Graft biopsy was done and was diagnosed as C3Ga. The disease progressed, and he lost the graft by 2 to 2.5 years post-transplant, and he was in dialysis then. To know the native disease and anticipate its recurrence, to keep maintenance immunosuppression at a higher level may help contain the primary native kidney disease. And genetic analysis. This is which is in the recent era that we have genetic analysis, which helps us to plan the outcome of the patient. For FSGS patients, for C3GN patients, the genetic analysis of the recipient and the living donor, and for a typical HUS, these situations, the genetic analysis is definitely supportive for planning the transplant. Calcineurin inhibitors toxicity. This is the next common cause of chronic allograft nephropathy. What is the mechanism of CNI toxicity? It's vasoconstriction, reduces the blood flow and oxidative stress. Increase in levels of pro-fibrotic factor TGF-beta in renal tubular cells, leading to fibrosis. Cyclosporin is known to cause more of this predisposition than tacrolimus. The advantage of CNI in the first year of transplant is a very good graft survival. However, there are no major benefits in long-term graft outcomes. I would like to discuss a case again over here. 42-year-old female, her native kidney disease was CGN, and underwent a preemptive ABO incompatible renal transplant in May 2015 with mother as the donor. Being ABO incompatible, she received rituximab as a part of desensitization, plasmapheresis, and basiliximab was the induction agent. She stabilized at the creatinine of 1.3 to 1.5 milligram per deciliter. Maintenance immunosuppression was prednisolone, mycophenolate mofetil, and tacrolimus. Here is the graph of her graft function post-transplant. So about 15 to 18 months post-transplant, the creatinine, it was creeping up, but the creatinine suddenly shot up to 4.5 from her slow rising trend. During this time, we did a biopsy which showed a CNI toxicity, and her tacrolimus doses were reduced, and she stabilized at the creatinine of 2.8 to 3 milligram per deciliter for another couple of years, until about 4.5 years post-transplant. She again had an acute surge in her renal dysfunction. She had required temporary dialysis to support her. And during this time, again, a biopsy was done, which didn't show major changes other than interstitial fibrosis. At this time, her low-dose tacrolimus was completely stopped, and she was kept on only dual immunosuppression, mycophenolate mofetil and visolone. Dose of mycophenolate mofetil was stepped up slightly, and she slowly, over a period of next 1 year, that is 10 to 12 months, stabilized at a creatinine of 3 until her last follow-up, where she's at creatinine of 2.9 to 3 milligram per deciliter. So this is a very classical example of CNI toxicity, which was biopsy proven, and withdrawal of CNI definitely helped graft stabilization. About 100% of adult transplant recipients show some histological evidence of CNI toxicity by 10 years post-transplant. There is a pediatric study wherein a CNI-free regime was used, and it involved induction with sirolimus, anti-CD25 monoclonal antibody, and maintenance prednisolone, sirolimus, and mycophenolate mofetil. And identified no evidence of interstitial fibrosis and tubular atrophy in the protocol biopsies done at 1 year post-transplant. And these were the patients who did not face any rejection during this first year post-transplant. However, we do not have their long-term outcomes. What are the various ways how we can minimize the CNI? So we can either reduce and stop CNI completely and switch the patient to dual immunosuppressants with maybe increasing the dose of mycophenolate mofetil, low dose CNI and everolimus. So we introduce everolimus and we develop a low dose CNI below 5 nanogram per deciliter. So that's the quadruple regime. Replacing CNI completely by everolimus over a period of time once a steady level of everolimus is achieved. So again, we come to a triple drug regime where CNI is replaced by everolimus. And if the kids are on dual immunosuppressant, CNI and visolone, and no antimetabolite, maybe switching from CNI to antimetabolite to reduce the CNI toxicity. However, we have to be very cautious, and a close follow-up should be maintained when we are minimizing CNI, reducing or switching over to everolimus, because minimizing may result in higher rates of subclinical rejections or acute cellular rejections and progression to chronic allograft nephropathy. So salvaging from chronic allograft nephropathy due to CNI toxicity, we may push someone into a chronic allograft nephropathy due to rejection, wherein a very close follow-up and a continuous monitoring titration is going to help. Proteinuria at this stage is going to be a very, very important marker for us to pick up upcoming rejections. Aldactone. So this is a mineralocorticoid receptor antagonist, where the studies have been suggesting aldactone to be helpful in minimizing minimizing the fibrosis due to a CNI toxicity. So it's a very famous trial, Spirene trial. Now, how does it work? Spironolactone acts on the intracellular mineralocorticoid receptor and blocks it. What does this mineralocorticoid receptor do? So it has a salt and water balance plus inflammation, vasoconstriction, and oxidative stress role, and that predisposes to tissue fibrosis. Blocking this receptor helps in reducing the fibrosis. It is proven in reducing myocardial fibrosis and hence used in heart failure. And a similar extrapolation to kidney and helps through a parallel mechanism helps in reducing fibrosis in chronic allograft nephropathy. Its use has been extended even beyond CNI toxicity in any chronic allograft nephropathy. Next, we come to the infections as the cause of chronic allograft nephropathy, and BKV is the most common among the infections responsible for chronic allograft nephropathy, CMV, and EBV predisposing to PDMD. When does a BKV viruria happen? So it occurs in naturally immunosuppressed states like pregnancy, in malignancy, HIV positive patients, diabetics, and transplants who are on immunosuppressants. BKV viremia occurs in 13% and BKV nephropathy occurs in 8% of kidney transplant recipients. Now, what is this pathogenesis? How does this BKV affect? So there is a virus reactivation. We have our strong immune system has suppresses this virus in the body. Once we are on immunosuppressants, virus reactivation happens. It increases by lytic process. The number of virus increases. There are large nuclear and perinuclear virus-loaded inclusion bodies in the tubular cells of the kidney. The lysis of these cells causes dissemination of the virus, and when the peritubular capillary is damaged, it leads to the hematogenous spread, and that is how a BKV viremia happens, and that causes interstitial inflammation. So there is tubulitis, necrosis, apoptosis, fibrosis, and allograft dysfunction. BKV antibodies are there, but they are not found to be protective, so they don't have any clinical significance. What is important is a cytotoxic T lymphocytes, which acts to destroy the BKV. So whenever there is a viruria, how can we pick it up? So it is a DNA PCR in urine or RT-PCR RNA or decoy cells. These are the inclusion-bearing denuded epithelial cells. So we can test urine for decoy cells. Viremia will be picked up by serum BKV PCR, and there will be a nephropathy with allograft dysfunction. So again, if there is an inadequate immunosuppression, it leads to rejection and allograft dysfunction and tubulointerstitial nephritis. If there is excessive immunosuppression, it can predispose to BKV nephropathy, again allograft dysfunction and tubulointerstitial nephritis. So multiple studies suggest that it is the net state of immunosuppression and not a specific drug that allows for development of progressive BKV infection. So there are many studies where CNI versus antimetabolites, cyclosporin versus tacrolimus, CNI versus mTOR inhibitors have been looked at whether what is predisposing to BKV. But the fact is there is no single drug which is attributed to have increased risk with BKV infection. It's the net immunosuppression state of the patient which is going to count in this situation. It seems to develop less frequently with maintenance protocols that involve steroid withdrawal or steroid-free protocols. And it is found more in cases of rejections because we have definitely immunosuppressed the patient more, and we tend to keep the maintenance immunosuppression at a little higher level in patients who face rejections. So they are predisposed to BKV nephropathy. When it is diagnosed early within the 6 months after transplant and the creatinine is still stable, the survival is improved compared when the diagnosis is late with a significant renal dysfunction. How do we manage this? I would like to discuss a case over here. 38-year-old female native kidney disease, chronic tubular interstitial disease, living donor related transplant in November 2020 with mother as the donor ABO compatible. She had received thymoglobulin and Solumetrol during her transplant. She faced ACR 3 weeks post-transplant, which was treated, and her creatinine stabilized to 1.3 to 1.5 milligram per deciliter. Creatinine started rising slowly to 1.8 in June 2021 and 2.3 in July 2021. She was positive for PRA both the classes. However, the SAB was negative. There was no proteinuria, and the biopsy was suggestive of BKV with coexisting CNI toxicity. The BKV PCR was about 165,000 copies. So what was done for her? The antimetabolite was completely stopped. The tacrolimus dose was gradually reduced to her last tacrolimus level of 4 nanogram per ml. And a ciprofloxacin and leflunomide were added. The BKV PCR viral copies were not detectable 2 months after the initial result in October 2021. The creatinine has now slowly come back to 1.8 milligram per deciliter in her last follow-up of November 2021. So this was a classic case with rejection, treated for rejection, and few months later, graft dysfunction and a BKV nephropathy. Now, what can we do for management? One is we reduce the immunosuppression. So we can withhold the antimetabolite, CNI reduction with addition of everolimus, or CNI withdrawal with addition of everolimus. Everolimus is found to be protective for BKV. What are the adjuvant treatments? So these are the other drugs which are found to be effective. Cidofovir is a cytosine analog and viral DNA polymerase inhibitor. It inhibits BKV replication. The dose is 0.25 to 1 mg per kg every 1 to 3 weeks. We do not have much experience in using this drug. Next is fluoroquinolones, DNA gyrase inhibitor, which is found to be helpful. Leflunomide, 20 mg daily. It's an immunomodulator and has been found very effective in getting negative viral copies. IVIG. It is immunomodulatory as well as potential anti-BKV properties. IVIG will be ideal when a BKV with a rejection is coexistent with rejection. It is there, so it helps both. 2 to 3.5 gram per kg over 2 to 7 days is the recommended dose. How do we monitor after a BKV infection has occurred? So we have to look at BKV viremia, BKV PCR in blood. Viremia usually clears in 7 to 20 weeks. We found in our case and another couple of cases, the viremia to clear by 8 to 10 weeks. If there is no reduction in viral load by 4 to 6 weeks after your initial modification of immunosuppressants, it would mean that there is a need for further reduction in the immunosuppressant. So sequential BKV viral levels needs to be done. So how do we do screening for BKV? So screening for BKV should be performed every 3 months for the first 2 years after transplantation, so that it's picked up early and intervened early, then annually through the 5th year, and as in when the allograft dysfunction happens or when a transplant kidney biopsy is performed. In summary, chronic allograft nephropathy is major cause of graft loss. There are donor and recipient factors. It's usually a combination of both immunological and non-immunological injury over a period of time. The histological features and specific features that suggest the underlying etiology are under regular revision. And protocol biopsies, management of subclinical rejections or early chronic allograft nephropathy with immunosuppression adjustment is going to help us slow the process of chronic allograft nephropathy and prolong the life of the graft. Thank you.
So thank you, Happel, for a very practical approach to management of chronic allograft nephropathy. Let us see if there are questions in the chat box. Any question about management of acute or chronic rejection? Well, if there are no more questions, then I think we'll bring this transplant update to an end. I think we have covered everything about transplant, starting from immunologic evaluation to induction immunosuppression to maintenance immunosuppression, identifying acute rejection, and then treatment of acute rejection and chronic allograft nephropathy. I hope this will be useful for those who have an active transplant program. And what we plan to do in future is come out with a series of talks on immunologic evaluation of transplant, because while there has been no significant progress in the immunosuppressive drugs, it's almost 20 years since we had our all this currently used immunosuppressants. There has been a significant progress in the field of transplant immunology, and in the coming year, starting January 2022, we plan to come out with a series of transplant immunology talks. With this, I would like to thank all those who have attended this session, and we would be very happy to answer the questions. Even if someone wants to put them later on, they can put it on WhatsApp, or they can send it to us by email. So thank you one and all for joining us for this transplant update. Anyone wants to make comment?
I think let us also invite inputs as to, what someone would like to understand more. So all of them who have attended this meeting, we will send off an email and you can write back to us as to what you would like us to take ahead. We will bring in experts. We will try to see that it is more practically oriented and more oriented towards day-to-day practice rather than only theoretical work.
So we know who have attended, and we can send a message to all of them for their comments
and feedback.
Yes. Okay, thank you. And I must thank Novartis for asking us to come up with this program. It is because of the support that we have come up with this transplant update program. I would also like to thank Torrent for their support. And last but not the least, Mr. Vipul Duwad, who has been patiently been there through the entire program for last 2 days, and for helping us in this virtual meeting. So with that, thank you all and wish you all good night, and hope to see you in our future programs. Bye-bye.